And we have, first of all, Clare Rayner, who is a consultant occupational physician. She's retired and no longer practices clinically, but she has done a 6-month obs and gynae job during her GP training in 1995. She also works as an artist after retiring from clinical practice on health grounds. So she keeps very close to health, which is fantastic. She's also a trainer, communication skills for healthcare professionals. She's worked on the National Education Project for Health and Work and was an honorary lecturer at the Centre for Occupational and Environmental Health at the University of Manchester. She has had long COVID herself, and she's spoken and written about it. And currently she's working with UK doctors and patient groups to develop appropriate health services for long COVID patients, because I think you'll see from when she talks, this is going to be a really important part of care on the ongoing months and years to come. She's also collaborating with the Department of Rehabilitation at Mount Sinai Hospital in New York. So she's truly a not just national treasure, but an international one. So welcome to us, Clare, and the screen is now yours.
Thank you very much. What a lovely welcome. That's so kind. Whilst I share the screen, I'm just going to tell people how I came to be asked by you to do this. And lovely. I have a very good friend called Dr. Amali Lokagamage, who I went to medical school with, and we shared a flat. And over the last few years, we've been collaborating together, me illustrating her second book, which is going to come out soon. We're waiting until we feel a bit calmer after some of the stuff to do with COVID has settled a bit, because it is about trying to find stillness through the sort of lens of maternity and childbirth and creativity. So I've just put a little picture of the baby that I drew for the front of the book, because I love that little baby. I don't know why, but I just do. So that's how I come here today. It's an unusual way, and it seems like a lovely setup. So I'm glad to just be able to share what I know. One thing has led to another with long COVID. I never would have imagined talking to anyone on the news or anything like that. But here I am, and I just feel very passionately for all the people that have been affected, really. So I'm just going to move my slides on. So yes, that's going to be the front cover of the book we've done together. And I think Amali also coined this beautiful phrase when we were talking. Well, it's a useful phrase. We were ill exactly the same time with COVID from mid-March, literally followed the same patterns. And the symptoms have been weird. And we recognised, well, she said they're remarkably similar, though bizarre. But she wasn't just talking about me and her. She was talking about all the other people we were starting to hear from. And we were kind of thinking also it's a sort of relapsing condition. That was also bizarre about it. You'd think you got over it, and then you get hit again. With my slides, there's quite a lot, and I haven't done them so that I'm going to talk through every detail of them. I know that some people like to have them to look back on, and so I have put references and stuff there. I think the first question is really, what is long COVID? And I'll give you some of what people are saying. So there's a professor of general practice called Trisha Greenall, who I've met, fabulous character. She really wrote the first all-encompassing article really about what long COVID was, but she did it because she talked to a lot of us. So she did a lot of interviews with us, and we were able, not just doctors and so on, but people with prolonged symptoms. And so she suggested in her paper that there might be 3 phases to a COVID infection. One being the acute phase, which, you could roughly say might be 3 or 4 weeks. She then suggested that the sort of intermediate phase between 4 weeks and 3 months you might call post-acute. And then anything after that she called chronic. Now, I think this is quite a good category because it does describe the timescales of things. But what we now know is 9 months on from when a lot of people contracted it, it's going on and on for a lot of people. So she doesn't say it's a perfect definition, but she tries to say, look, at least we have some phases we can help people to sort of work out, the doctors to work out what's going on. The reference is there. And she wrote a second paper where she'd done a lot of qualitative interviews with 114 people with long COVID, and these were wonderful. It was the first time I think some of us felt heard. And we were able to say, actually, this is not just a post-viral thing. It's not just fatigue. We've got organ damage, and most of us haven't been to hospital. We haven't received any care. So she just transcribed what we said, but that as well has been quite a game-changing article, I think. Then we linked up with a really lovely lady called Professor Lynn Turner-Stokes, who's a rehabilitation specialist, who just gets her head down and works. So she doesn't really respond to emails, but she's been in the thick of it. And I have put there a couple of links to some YouTube or webinars that she's done. She says it all. She says it all. And in one of them, she says it all in the first 10 minutes. She explains what she thinks it is. Now, she says that all the symptoms that people describe within long COVID are directly due to the virus themselves. This is not post-viral fatigue, she said. Mm-hmm. So she's that was really interesting, and I think I agree with her. The British Society of Immunology has put out a really useful shortish paper, which I think I have referenced, or you could easily look up with this. And they've said, look, we've got to look into what's causing these problems in these people. The three main theories that a lot of people are now looking at are, is there any reservoir of virus hanging around that sometimes is rearing its head again? That hasn't been ruled out. It hasn't been ruled in, but I think there are a number of people that may be happening. You'll have heard about the inflammatory response that people are getting. That seems to be a big part of it. Mm-hmm. All of these looking into. There are theories about viral infection triggering new autoimmune disease, and quite a few people have developed new onset diabetes or new onset autoimmune thyroid problems. This is really common. And I'm sure that you already know that people can develop clots. So there's all that going on. And then there's been things about children having a multi-system inflammatory syndrome, which is quite serious. But I think they're now finding that adults could have that as well. So I'm really skirting over some of the possible causes, but they're all up for research, really. And those top three are the main ones. I've put pregnancy down as a question mark because I personally am not able to tell you too much about how women's bodies react if they have COVID during pregnancy, and I suspect you will have more knowledge on that than me. So what do I conclude after all these months? What is long COVID? I conclude that all we can say at the moment is it is symptoms of COVID-19 infection that last more than 3 or 4 weeks, because we do not know yet what is going on for us that have had the duration. So I think that's what we have to be careful of, not assuming it's post-viral fatigue or any one thing, because I think it's complicated. And I've put down it's not one thing. And I think we should take each person and look at them as individuals. What is going on in this person? What are the factors there? I've put in bold there, you do not need a positive test to be diagnosed with COVID. I'm hoping this is old news, but I don't think it is, because many doctors and healthcare people are still saying, but you didn't have a positive test. We know for several reasons that they either weren't available or actually they're not that accurate. So I think that's just never say to a patient or a person, but you didn't have a positive test, because it's now been debunked. And the World Health Organization have set out criteria for how you can diagnose it clinically, which is what we should be able to do anyway. So it is a multi-system disorder. It's primarily a disease that infects the blood vessels, not the lungs. It just isn't primarily a lung disease. And I think that's probably what people got wrong in the first place. It infects the blood vessels, the really small blood vessels. I can hardly say this word endothelitis because I've never heard of it. So I think it means the tiny little blood vessels get infected. But I think that if it's a blood vessel infection, then no wonder people with cardiovascular disease or with diabetes are at really high risk. It kind of makes sense. So I think another take-home message is having long COVID is not necessarily mild because they weren't admitted to hospital. And I can see Elaine agreeing with me there, because most of us weren't admitted to hospital. Most of us were turned away because there were two criteria for admission. One is you had to be blue, and the other is that you had to be unconscious. And I'm not being facetious with that. That is how it was. So a lot of very ill people were left at home and really haven't received any treatment or assessment. Just to give you a flavour of a person with long COVID, somebody that works in a hospital, not directly clinical, but I think we can forget these people are frontline as well. Not admitted, age 40. Yeah. Oh, no, I've put age 32. Actually, I think I added another case in. I've put two cases of people in the NHS here because I think these are very typical. A young nurse, age 32, a very common problem would be now that they would be dizzy and the heart rate would shoot up, get absolute palpitations just on standing up. So even normal activities like dressing at home can be very difficult. And these people having several attempts at return to work. And I hate the word failing, but not managing. And I'll explore the reasons why. This is common. The second person was this admissions clerk who was ill at home, not admitted, initially short of breath, cough with nasty phlegm, and a bit confused. I think I was very confused in the first 3 weeks. I think I was doing some bizarre things, but that's looking back. She continued and has continued to this day, 9 months on, with fatigue, headache, severe headache, like migraine, dizziness, palpitations, and poor memory. These are very common. Severe facial pain, like trigeminal neuralgia, and low oxygen saturations, because the GPs are telling us get home oxygen monitors and check them. This is also very typical. No healthcare hasn't been able to get to see anyone. Diagnosed at 3 months with migraine and anxiety. We encouraged her to ask for a brain scan and respiratory investigations because the brain stuff wasn't normal. Diagnosed at 7 months with a cerebral vein thrombosis due to COVID. Had been told there was nothing wrong. So I won't go through these things in detail, but we talked to the World Health Organization. The patient group asked me to, and we spoke to Dr. Tedros. We didn't know he was there. We just said what I've said to you and said, look, this is really something. And at the end of the meeting, they handed over to him and we could not believe it. And he said, we hear you. We will do something about it. And he's now put this out, which he says it's a fluctuating condition with a vast spectrum of symptoms and can affect any part of the body. I'm just going to keep an eye on the time, if you don't mind, just while I have a look at that. Yeah. So I think I've said there, people have not been admitted. They've not been counted. We don't know how many people are out there with this. We just all know people, don't we? The majority weren't admitted because there was this very, very high bar for admission. People attended A&E several times, and whether they were admitted or whether they went to A&E, with these high heart rates, I can tell you, they got told it was anxiety. That's a kind of medicine I don't recognise, because I don't go straight from thinking somebody's got a heart rate of 140 to thinking it's anxiety in the context of a pandemic. So I'll leave you to read the rest of what Dr. Tedros said. These, I think, from the work the notes we've compared on patient groups, are the commonest symptoms in long COVID, not what happens at the beginning. Chest pain. My goodness, I realised 6 months in, and it took me 6 months because I know I have normal coronaries. I realised I was getting angina, absolute classic angina. This is really common starting at 3 months for a lot of people, all ages. The palpitations and the dizziness. And You might have heard people mention brain fog, and I think you've got to ask your patients, what do you mean when you say brain fog? Because I think that's different things for different people. I always, what do you mean? But commonly, people have lost their short-term memories. They're finding it difficult to take information in, and that can affect concentration and so on. Another thing is people very commonly can't find words out. That's not really reported anywhere, but you cannot find the right words, and that seems to be a thing. I had a very hoarse voice until about a week ago, and suddenly it's got better. Skin rashes, sleep disturbance, fatigue, terrible muscle aches, breathlessness, and so on, and a whole load of neurological problems. Perhaps Elaine will say more about the type of things that she's had. The strange patterns, Amalia and I said, this is like malaria. Not that we've had it, but when we were at medical school, we were taught about some forms of malaria. You would get this fever every third or fourth day, and then it would die down again. So we felt there was something about the virus being taken into the red blood cells and released, and in some people, they do now think it's something to do with it gets into the red blood cells and affects the oxygen transport. I've put some blogs down that we wrote because I think they're easy to read. And the one that I think Amalia was really particularly leading on was patient experiences are missing from this narrative. And we said what I'm saying now. Sorry to whiz through this, but this is just my visual of what it can be like. There are all these different patterns. Those that are feeling terrible at the start and stay feeling terrible and still haven't got better. But then there's this up and down pattern, and that's quite common. I sort of had that third line down where I was ill for the first 2 or 3 months, really bad, and then up, down, up, down, up, down, and gradually got less. I'm fairly certain that I still had virus all over the place because my last blast led to a really nasty bacterial infection. That's to do with my underlying problems. So different things in different people. Again, let's not assume one thing. So I think this is maybe all sort of stuff that you might see in your patients, or as Sue said, some of you may have had this or have relatives who do. I'll let you just look at that one. But at 3 months, I haven't put on here about the NICE guidance because it says that people don't develop any new pathology after 3 months, and that's simply not true. The new pathologies are arising all the time. So just to summarize, these are not the symptoms, but these are the actual organ problems that are being found very commonly in people with long COVID. The top 3, cardiac damage and cardiac arrhythmias. This is the commonest. The neurological, which is the brain things, and neurocognitive. And I hope these are getting better for people as time goes on, but we'll have to see. And then this biggie, which is the autonomic problems. Remember that I gave the example of the young nurse who had dizziness and palpitations standing up and actually couldn't complete a shift when she went back. What is being found is that people have POTS, so the postural tachycardia syndrome. And this is an autonomic derangement. So viruses, apparently, I heard from an expert last week, are known to trigger this autonomic reset, if you like. And in the case of COVID, it's the POTS. So they get dizzy on standing, they can't keep their blood pressure up, so their heart rate goes sky high. And I think this is why a lot of people are failing on phased returns. The prof that was telling us about this last week said it needs slow, careful attention to all sorts of lifestyle factors and perhaps specialist physio. So I think we need to be looking at how we rehab these people. Now, I also know, I have hypermobile Ehlers-Danlos loss, and it's a multi-system disorder. And so I have the autonomic stuff, and I know that a lot of women in pregnancy will have these sort of autonomic POTS type disorders. So they may particularly struggle if they've also got COVID. I'm going to just briefly, I'll let you read those other symptoms. There are loads. Here's a study recently done on people who were not hospitalised in the UK, and they've scanned several organs. And in people with long COVID, this is 6, 7, 8 months down the line, 33% of their 200 patients had damage to one of the organs. Nearly 2/3 had damage to more than one organ. And you can see that the biggest group there is in the cardiac. What they say is, thankfully, these damage is mild and they hope it will improve. But I think it's kind of rebutting this story that it was all in people's heads, which is what they've been given. I'm just going to I put some pictures in. I mean, those are the facts about what I think about where we're up to with what long COVID is and how people are being affected. I'm no expert. I cannot tell you about particularly how this will affect women in pregnancy, but it might give you some food for thought and maybe to explore more. And this is just one of the pictures that I've done for Marley's book. And this one's called Doula, or is it Embodied Wisdom? I can't remember. But I love bodies, having been a healthcare professional, and I just think maternity and all of this is particularly beautiful. So I was imagining myself in that. Okay, so I think that headline is really health problems with the largest impact on their functioning. I've mentioned them already, the POTS. Mount Sinai Rehab say they are seeing patients who are more extremely deconditioned than you would expect with any other viral infection. We don't know why. As time goes on, I think a lot of people are getting better. But the other thing to say that's big, and the occupational health professor that contacted me recently said, the most troubling thing is the sense of trauma that people are displaying, not anxiety or depression, sense of trauma at not being believed. And that perhaps that's the best thing you can do for people who've had this. I believe you, tell me what's been going on. I know there's various guidance for you on COVID in pregnancy. And I'll pass over this because this is the government advice on pregnancy. Are pregnant women more at risk of getting COVID? I don't think so, but they have put them in the moderate category just in case there's a risk to women. I think that's probably a wise and sensible decision. It just says, okay, be cautious. We can't say there's absolutely no problem. I hope by the time that people have been through their pregnancies and their deliveries, they're going to have they're going to be in this position. That was actually my baby niece at 2 weeks, and me. I just felt very peaceful. And I think just a couple of minutes, really, I know I have to finish, but what do you need as midwives, perhaps, or as employees? What do you need and what can employers do? This is a little picture from Marley's book. She asked me, she's called it receiving information. I said I did my obs and gynae job 25 years ago. This is what the labour ward office looked like then. I have no idea what it looks like now. Is it similar? No change. And you can see that people are like, yeah, I'd rather get on with my coffee. But that's hospital life, isn't it? I suggest 4 categories that you should expect to be looked after by your employees and what they can do. And I think it's this understanding, which I've said about. Not suggesting that you advise treatment, but I would like to think that you could try some treatments that work if you had these problems. That purple quote is from a psychiatry person with long COVID, and it's what I said about understanding. Validation as a subcategory of empathy is a basic human psychological need. I think that's beautiful. If you have symptoms yourself that have carried on and on and on, there are things that can really help, and that's getting to a cardiologist or even your GP as information gets through. Beta blockers and that type of thing can help slow heart rates and have transformed people's recovery within a couple of weeks. Antihistamines, painkillers for the neurological pain, and a lot of people quite legally taking melatonin for the sleep disturbance. So there are things that you could ask your doctors about. These are dramatically helping some people. And I'll let you read through these, but occupational health services should help. What we'd say is if you're off sick, try to maintain some daily structure. They should be signposting you back to GPs and specialists for treatment. You could ask your managers And this is not a joke, if the employer would consider funding scans and investigations if you're struggling with delays, because it costs far, far less than having people off work for months. And you're going to need long phase returns. That needs long, tailored phase returns. I think I'm going to leave it there because I know that I've probably spent much more time than I should. There are other slides, but on there are these are the sort of things you should expect if you're off ill or coming back to work. And there'll be a few more things. And please feel free to raise those with your managers and human resources should you be in this situation. Thank you so much.
Thanks for watching this video from the Maternity and Midwifery Forum. For more expert opinion and analysis, hit the button below to subscribe.